नमस्कार मंडळी, मी प्रसाद अथणीकर, महाराष्ट्र मंडळ शिकागो 2023 चा अध्यक्ष. तुम्हा सर्वांचे या विशेष आरोग्यधाम सेशन मध्ये स्वागत. आज आपल्याला विशेष स्पीकर मिळालेले आहेत आणि एक इंटरेस्टिंग टॉपिक आहे आणि महत्वाचा टॉपिक आहे. तर मी आपल्या नगरकर जे याच्या ट्रस्टी आहेत आणि त्यांनी आरोग्यधामचे ऍडमिन व्हायचे पण ऍक्सेप्ट केले यावर्षी. तर त्यांना मी विनंती करतो की आजचं सेशन
धन्यवाद प्रसाद. नमस्कार मंडळी, शुभप्रभात. आज रविवारी सकाळी उठल्याबरोबर आज तुम्हाला एक महत्वाचा विषय ऐकायला मिळणार आहे. आपण मागच्या वर्षीच आरोग्यधाम हे एक नवीन कट्टा सदर चालू केलं होतं. माझ्या बरोबर दीप्ती भाले गोवर्धन या देखील आरोग्यधामच्या ऍडमिन आहेत. आज आपल्याला ज्या प्रमुख वक्ता म्हणून जिथे लाभलेल्या आहेत त्या रचिता निकम या सेंट लुईस मिसुरी इथे वास्तव्यास आहेत आणि त्या लायसन्स सर्टिफाईड जेनेटिक काउन्सिलर working in Department of Pediatrics Genetics at WashU. She specifically works with cancer patients and with the patients who have a family history of cancer. Her expertise area lies in evaluating family histories and personal medical histories to determine if additional genetic testing is recommended. She works with her patients to help them understand the intricacies of genetic testing and help other family members understand the importance of such results on their health with regards to prevention, screening, and early detection of cancer. हा आजचा अतिशय महत्वाचा विषय आहे आणि मी आपल्या सगळ्यांना निवेदन करते की आज हे पूर्ण सेशन आपण ऐका. आपण तिच्या ह्या एक्सपर्टीजचा लाभ घेऊया. सो वेलकम रचिता and please start the session. Thank you.
Thank you so much, Ulkatai. I will start sharing my screen. Just a minute. Good morning, everyone. My name is Rachita. दोन तीन गोष्टी मला I wanted to start by disclosing. I am not a doctor. I'm a genetic counselor. I'm a board certified genetic counselor and I have a valid license to practice in the state of Missouri and Illinois. I have no other conflicts of interest to disclose. I wanted to start the session by thanking all of you for joining and listening to me today this morning about such an important topic. Cancer mantla, when we talk about cancer, it's a very scary subject. I wanted to try and make this information about genetics, which is a whole another subject, and cancer accessible for all of us today. So that is going to be my attempt. To begin with, I wanted to start by defining a few terms. What are genes? What do we mean when we say the genome? And how is all of this related to DNA? So our genome is nothing but the instruction manual that tells our body how it's supposed to behave. I want us to think about our body as a machine. And if we think about a machine, every machine has an instruction manual. Every machine comes with an instruction manual that helps that machine operate the way it's supposed to operate. So our genome is the entirety of the manual. Our genes are specific instructions in that manual. So our genes are instructions that tell us what color our hair is going to be, what color our eyes are going to be. Our genes also tell us things on a cellular level. Our body is made up of 33 trillion cells. Each cell has all of this information packaged within it, and each gene carries out a different function. Now, when you think about it, the instruction manual is one way of looking at it, or you can think about it as a recipe book. Recipe book has a lot of recipes, right? So each recipe is a gene. The entire book itself is the genome. DNA is the language in which this entire book is written. So the entire genome is written in the language of DNA. Now the problem is our body does not understand the language of DNA. So within our body, all of this information, all of these genes are converted into the language of RNA. And then our body understands the RNA language, forms a protein, that does the work for the instruction, which is the gene. Each gene carries out different functions, like I said. Global functions, like what color our hair is going to be, what color our eyes are going to be, but also cellular functions. For example, how to convert the food that we eat into energy that is needed for our body to work and perform other activities. All of this is operated on a cellular level, like I said, and our body has a totality of 20 to 25,000 genes. We inherit our genes from our parents. We get them from our mother and from our father. And a lot of times, this is something we know. Whenever a new baby is born, whenever a baby is born, we say things like, she has a father's nose, she has her mother's eyes, right? So these are things that we know, that we get our genes from our parents. And everyone knows that we get half our genes from our mother and half our genes from our father. So when we say half and half, it feels like all of this comes together equally fitting to make a complete you. But actually, what happens inside our body is that for each gene, one copy comes from our mother, one copy comes from our father. All of this information, when it comes to our genes, is packaged, right? 20 to 25,000 genes in the genome. All of this is packaged into chapters called the chromosomes. So the human body has 23 pairs of chromosomes, or a total of 46 chromosomes. 22 pairs are autosomes, and the 23rd pair is the sex chromosomes, which determines whether it is going to be a biological male or a biological female. Okay, general overview zara. Genetic disease bhantla ki we start talking about mutations. So one thing I wanted to make clear is all of us have mutations in our genes. Mutation manje kai? So mutation is just a change in our genetic information. माझे जे genes आहेत, the genes that I have in my body are not going to be the same as the genes that you have in our body and in your body. And that is very natural. That is just human variability. So in each specific gene, it is very common for a person to have mutations. When does a disease happen? It happens when there are mutations in that gene that either make that gene work more than it's supposed to, or mutations in that gene that stop that gene from working the way it is supposed to. So nowadays in the medical field, what we try to use, the term that we try to use is a pathogenic variant or a pathogenic mutation, something that stops that gene from working the way it's supposed to. Mutation, when we start talking about mutation, we start thinking about X-Men. So having a mutation in your genes does not make you a mutant, because if that was true, then we would all be mutants. Genetic disease can be caused due to different types of inheritance. Autosomal dominant and autosomal recessive. These are two different types or forms of how we can inherit or get a genetic disease from our parents. Okay? When we say that we have one copy of a gene from our mother and one copy of a gene from our father, autosomal dominant inheritance means that if you have one copy switched off or one copy not working properly, the other one is not enough to tell your body what it's supposed to do. So having just one copy not working properly is enough for that person to present or show the signs and symptoms of the disease. As you can see, your graphic Varun, you can see that autosomal dominant inheritance asla, if mother or father has the condition, then 50% of children. So with each child, either the child has the condition because they inherited that particular change in the gene, or the child does not have the condition because they did not inherit. So you see patterns where each generation has a person with the disease or with the condition. Autosomal recessive is different. Some genes, even though you have two copies, when you have two copies of that gene, in some genes, एक copy switch off झाली, so that's okay. Current the second copy of the gene is enough to tell your body how it's supposed to behave, what it's supposed to do. So in autosomal recessive genetic disorders or conditions, both copies of the gene need to be switched off. Now, in this, what that means is for a child or a person to have that condition or present with the signs and symptoms, both mom and dad have to have a change or a alteration or a mistake in their genes. So having just one copy of the gene switched off is not enough for you to present with the symptoms of the disease or the signs of the disease. This is a general overview of genetics, how we inherit our genes and how they work inside our body, how they are related to disease in general. Next, I wanted to talk about cancer itself as a disease. And first and foremost, thank you all for listening to me on a Sunday morning talk about cancer. This is a little intimidating, but I wanted to make it accessible. Cancer is nothing but a bunch of cells inside our body that are doing what they're not supposed to. So there are a bunch of cells inside our body that are misbehaving. They're growing in a place that they're not supposed to, or maybe a rate that they are not supposed to. Our cells, 33 trillion cells in our body, each cell has its own life cycle. Each cell forms anew, divides into newer cells, and once it is done doing its job, is supposed to die. All of this is controlled within our genome through our genes. Now, when these cells don't die, keep growing, continue to grow, or move to another part of our body and continue to grow, that is what we call cancer. So it is a disease caused by uncontrolled growth and division of abnormal cells within the body. It is a leading cause of death worldwide. According to the WHO in 2020, cancer was a cause of death for 10 million people. In the United States, 1 in 3 people will be diagnosed with cancer in the period of their lifetime. Every third person walking down the street. That is a lot of people with a diagnosis of cancer. According to recent data, in India, right now, 1 in 9 people are likely to develop cancer in the period of their lifetime. The most common diagnoses in 2020 in the United States are breast cancer in women, lung cancer in men and women, and colon and rectal cancer in men and women. Of all of these, the most common diagnoses that led to death are lung cancer, colon and rectal cancer, and liver cancer. Now, according to Indian statistics, lung and breast cancer were the leading sites. Lung in men and breast cancer in women were the leading sites of cancer diagnosis in India. The incidence of cancer diagnosis is estimated to increase in the next 5 years by 12.8%. So this is important information to know. It is important information to be aware about, and it is important information to discuss with other family members also. It is a very common disease, and we don't really like to think about it. But I am asking you, urging you all to really think about what are the risks that exist in my life that can put me at an increased risk for cancer. Now, first and foremost, cancer is a multifactorial disease. Manje kai? What that means is that our environment, our lifestyle, our process of aging, and our genetic makeup, all of these things contribute to our risk for cancer. When we think about risk factors, there are certain risk factors that are modifiable. Then there are certain risk factors that are non-modifiable. Modifiable risk factors are usually risk factors that are lifestyle risk factors that we have control over. Before I start talking about these modifiable and non-modifiable risk factors, मला एक गोष्ट तुम्हाला अजून सांगायची होती की when we think about cancer and it being multifactorial now, it is very hard to determine what each individual specific risk is for cancer. And that is because each individual has a different threshold of what their body can and cannot tolerate. So imagine that each individual has an internal jar. Okay. And some people have a jar that is broad and tall. Other people have a jar that is small and narrow. Okay. Now, people who have a jar that is broad and tall, you can keep adding risk factors, and the water in that jar will never overflow. If we assume that the water overflowing is the diagnosis of cancer, someone has a jar that is big and tall, you can keep adding all of these risk factors. On the other hand, if someone has a jar that is small and narrow, the slightest of risk factors can cause that jar to overflow. And that is why we see where some people have the worst lifestyles, never exercise, never eat good food, and still will never develop cancer in the period of their lifetime. And then other people who lived a good life, who lived a healthy life, who live a healthy life, and they may still be faced with a diagnosis. Now, even though we know all of this about cancer, it is very hard scientifically and medically right now to find out what does your jar size look like and what does my jar look like, right? We know that there are risk factors. We can quantify those risk factors and change them, but we don't know what my jar size is, what your jar size is. And that is why we try to give blanket statements to everyone when it comes to modifiable risk factors. Tobacco use. So that is not just cigarettes and cigars. Even chewing tobacco causes an increased risk for cancer. 1 in 5 cancer deaths are caused due to tobacco use. Tobacco use is not just associated with lung cancer, but is also associated with throat, bladder cancer, and actually esophageal oral cancer. Alcohol use is associated with oral cancer, throat cancer, primary liver cancer, as well as lung cancer. Alcohol use in women is a known risk factor that increases risk for breast cancer. Diet is another part that you can control. When you have a low fiber, high fat diet, that is associated with an increased risk for cancer. If someone eats a lot of smoked meats, that is associated with an increased risk for gastric and esophageal cancer. Salt preserved food causes an increased risk for lung cancer. Obesity, having a BMI, body mass index, over the age of 30 is associated with an increased risk for gallbladder cancer, is associated with an increased risk for breast cancer in both men as well as women. Increased BMI, obesity, or high weight gain is associated with an increased risk for uterine cancer in women younger. So, good diet, exercise, healthy lifestyle, reduction of all of these external risk factors is protective for us towards our development of cancer. Then other things that we can control or identify are infectious agents. Having an infection of hepatitis B or hepatitis C causes an increased risk for liver cancer. Having an infection of human papillomavirus or HPV causes an increased risk for cervical cancer. H. pylori is a very common bacterial infection in the upper GI tract. It causes an increased risk for gastric or stomach cancer. UV radiation, ionizing radiation, like getting a lot of X-rays, can increase a person's risk for cancer. 2 to 4% of all cancer diagnoses are attributed to occupational exposures. So if you work in a manufacturing company, if you work in a lab, if you're dealing with carcinogenic agents, and there are certain protocols and safety protocols to be followed, those are important. Those protect you because you don't know what your threshold is and how much has already been added to your jar. Now, there are certain non-modifiable risk factors that we do not have control over. For example, aging. The longer you live, the more things your body is exposed to, the more risk factors your body is exposed to, and that's why there is an increased risk associated. After 65, everyone's risk for cancer is significantly increased because your body has been exposed to all of these things, regardless of what your lifestyle looked like. That is why there are a lot of age-related screening protocols that are available, at least here in the United States right now. Those are things that you can definitely discuss with your primary care physician. Your regular practitioner will be able to guide you as to what best strategies to use to screen for cancer. Even though we don't have a good vaccine or a immunization for cancer, we know that early detection, screening really helps reduce the morbidity and the mortality related with cancer. Ethnicity or race is also important here because there are certain genetic changes that are more commonly identified in certain ethnicities. Ashkenazi Jewish ancestry म्हणून असते. In the population of Ashkenazi Jewish individuals, we find a higher percentage of prevalence of BRCA1 or BRCA2 mutations. That's why ethnicity and race can also be associated with an increased risk for cancer. Another example is melanoma. The incidence of melanoma in Australia is 51 people in 100,000 in a year, as compared to Zimbabwe, which is closer to the equator. So there's a higher impact of the UV radiation. However, in Zimbabwe, because of the melanin in their skin, the incidence of melanoma is 2 in 100,000. So ethnicity and race, and there are differences again with how they present with the disease. Sex or gender. The risk for cancer is thought to be higher in men as compared to women. And current data suggests that that's probably because of increased use of tobacco, alcohol, and exposure to other occupational things. These data or data points keep changing and keep evolving as we gather more information through the general population. Heredity is something that we are going to talk about in detail when it comes to non-modifiable risk factors. So I'm going to leave it at that for now. I wanted to spend 1 second here talking about chronic medical conditions. Gastritis, colitis, pancreatitis, inflammation diseases of inflammation that are chronic, where your body is constantly inflamed, we know are associated with an increased risk for cancer. So think about it like in a machine. If one part of that machine is constantly getting stressed, that part is going to give a lot more problems. And that is similar to having a chronic medical condition and having that increased risk. When we talk about cancer and genetics, when I talk about heredity and cancer, I'm going to talk about specific genes. So think about it like the specific recipe, right? Overall recipe मध्ये recipe चुकली तर डिश चुकणार, बरोबर आहे. पण पूर्ण चॅप्टरच चुकीचा असेल किंवा चॅप्टरच एक्स्ट्रा असेल तर त्याचा पण इफेक्ट होऊ शकतो. So chromosomal abnormalities or anomalies are where, if you think about our genome as a book or an instruction manual, all of this information is packaged in chromosomes, right? Now, some people have extra chromosomes or missing chromosomes or parts of their chromosome missing. That is called trisomy 21 or Down syndrome, Turner syndrome, Klinefelter syndrome. All of these chromosomal abnormalities, because there is a difference in the amount of information, amount of genetic information that our body is getting, that can also cause an increased risk for certain cancers. So individuals with these chromosomal abnormalities have a lot of other health issues, but also have an increased risk for cancer. Now, how is it all connected, right? So our genes, first and foremost, like I want to clarify, our genes do not cause cancer, okay? There are certain genes inside our body that work to protect us from cancer. These are called tumor suppressor genes or proto-oncogenes. So tumor suppressor genes काय असतात? Tumor suppressor genes can be gatekeepers, which means they're working to manage the cell growth. They can be caretakers, which means they work to make sure that the genetic stability of the cell is intact. So काही exposure झालं आणि जराच बदलली gene. So these caretaker genes come and repair that. Or landscapers, which means they make sure that the cellular environment is the best environment for growth. Proto-oncogenes are converted to oncogenes. Oncogenes are growth promoting genes, which means when they are deactivated, when they are in their proto-oncogene form, they are not doing much. When they become oncogenes, they increase the proliferation of the cell. They make the cell grow fast and fast and fast, right? Cancer is not a single step process ki genetic change झालं आणि cancer झालं. It is a multi-step process. So it starts with initiation. There is something that goes wrong in a single gene in the cell. Then because of that one mistake, one change, it causes multiple downstream changes, multiple downstream acquired mistakes. So that is called promotion. So it starts with initiation, then cell growth is promoted, then the disease progresses, and then finally the disease metastasizes. Usually a diagnosis is made in the early progression or late progression of the disease. So initiation and promotion ह्या गोष्टी झालेल्या असतात by the time a person gets a diagnosis. Okay. When it comes to specific genes that cause an increased risk for cancer, if our genes do not cause cancer, then how is it that people without any of these genetic changes, why do people still get cancer? That is a very logical question to ask. If there are no genes inside our body that cause cancer, and there are genes that protect us from cancer, then how is it that people still get cancer, right? That is because of how our body works and operates and how many things our body encounters in the period of our lifetime, right? When we think about genetic testing, why we think about genetic testing or an increased risk or inherited risk is because if a person has one gene coming from mother, one gene coming from father, okay? And these genes are protecting us from cancer. For this person to develop cancer, what happens is that they start with these two working copies. And over multiple decades, 10, 20, 30 years, because of environmental lifestyle exposure, one copy may switch off. काहीतरी mistakes झाली, internal errors पण होऊ शकतात in our body. Our body can also make mistakes. So one of these genes may switch off and stop working properly. But these genes are such that you don't need both copies to work. The second copy is enough for our body to sustain and to live the rest of our lives. So for 2 out of 3 people, 1 in 3 people get cancer in the period of their lifetime, right? So for 2 out of 3 people, this second copy never switches off. They die due to other reasons or other health causes. For 1 out of 3 people, the 10, 15, 20, 25 years down the line, second copy also switches off. Now there is no protection. So the cell starts mutating further, and then a tumor or cancer is formed in the body. Sometimes in certain families, what happens is that a person, instead of being born with 2 copies of this gene, either from their mother or from their father, inherits a mistake or a pathogenic mutation in one of these cancer genes, which means to begin with, instead of having 2 layers of protection, that person is born with just 1 layer of protection. Now that means only 1 copy, no safety net, na? So then that person is at increased risk for cancer. In that family, you start seeing more and more people with cancer because a lot more people with that mistake or mutation are at an increased risk. And that's what we try to do, or we talk to our patients about when we see certain family histories or certain patterns in the family. That same gene now, working to protect us from cancer in one part of the body, is present through the rest of our body. So wherever it is active, you have lost that layer of protection, and you may be at an increased risk for cancer in those parts of your body. And that is where we come in to talk about genetic testing, to talk about how all of this information can be useful in the moment, in the process of screening or treatment. Now, one thing I want to clarify is most times cancer has nothing to do with an inherited risk. in about 65% of our patients, a cancer diagnosis is sporadic, or we think is sporadic, meaning that it is happening because of external reasons: environment, lifestyle, process of aging. In about 25% of patients, we see that there are certain patterns in the family, but on the genetic test, we don't find an answer. Now, that may be because that family is living in an area where there is a lot of chemical pollution, right? And shared environment is causing that increased risk in that family. So we call it a familial risk. It may also be that everyone in the family is a chain smoker. So obviously, we will see an increased risk of cancer in that family. But that is because of shared lifestyle. But it is also possible that medical technology today does not know which gene is causing that increased risk in the family. Even though we tested, we don't know everything there is to know about our genes as of today. So when there is a familial risk, in 25% of our patients, when we see patterns in the family, we say that there is a familial risk. We say that other members of the family, regardless of your genetic test results, should be aware of the family history and discuss that family history with your doctors. Genetic testing identifies an answer. A genetic risk, a specific genetic risk is identified in only 5 to 10% of our patients today. But the identification of that risk can lead to significant changes in a person's medical management or treatment decisions. When you're talking to family members, if you're interested in all of this information, there are things that you want to discuss with your family members, information that you want to document. And this is information I definitely want to share with our community. When we are talking to our family members, आपण गप्पा खूप मारतो आपल्या लोकांशी. या गप्पा मारत असताना, it is important to make a note of age and date of birth and cause of death. It is an awkward conversation to have with a lot of our extended family and relatives. But it is important information when it comes to risk assessment. If एक side of the family doesn't have a lot of women, right, that could be masking a risk for breast cancer. If एक side of the family, a lot of people died young, be accidental death, maybe because of some other reasons, that could also be masking risk. And then you need to be aware ki, oh, I don't really know what the risk is on that side of the family. So maybe I need to be a little bit more aware of my body in those respects. Specific cancer risk assessment, Mantla, the things that you need to think about are who in the family has had a diagnosis of cancer, right? When it comes to our families back home in India, also realize that in India, there aren't regular screening protocols being done. So a lot of times a diagnosis is made in late stage. So when you ask, you should also ask about the age at diagnosis and where the primary location or site of the tumor was. Whether that was the only time the cancer happened or did it metastasize? Did it go somewhere else? Did it come back? Any other diagnoses of cancer? Any other tumors that have not been evaluated? People do not like going to the doctor. Let us be honest here. People don't like going to the doctor. Haan, ho jayega, dekha jayega. That is very common attitude, not just in our community, but across the world. Okay. गरज नसताना डॉक्टर कडे कोणाला जायला नाही आवडत, but people talk about tumors. अरे, there is a mass here. काहीतरी होतंय तिकडे. How many people have had असे tamok tengur masses around their body, right? So non-specific tumors, unique skin spots or patterns. Sebaceous neoplasms are boils on your skin that look like water boils. Cafe au lait macules manje, there are brown colored patches on your skin that have been present since birth. So someone who is born with those unique skin spots or patches. Vision or hearing loss at a young age. Now, vision and hearing loss, there are a lot of different reasons that can cause vision and hearing loss. Not all of them are associated with risk for cancer. But in some families, sometimes what can happen is that there might be a tumor growing that presses against a nerve, either the optic nerve or the vestibular aqueduct, the inner ear mantat. So those kinds of things. Young or early deaths, cause of death unknown in the family. And then people who have specific medical problems for themselves, it is useful to know whether they had a history of smoking, what their lifestyle looked like, were they overweight. This is when it comes to cancer risk assessment. Now, generally, when you're thinking about your family history and genetic risk mantla, so you need to think about birth defects, intellectual developmental delay, any infertility, anyone born with heart issues, anyone born with, or not born with, but anyone who developed diabetes, history of stroke, multiple pregnancy losses, a lot of babies who died in infancy, someone who is very tall in the family or very short as compared to the family. All of these could be signs and symptoms of genetic disease. माझ्या slide deck मध्ये I have included a website that gives information about how to think about family risk and how to talk to family members about this risk. ही मी slides सगळ्या ज्या आहेत त्या आपल्या MMC बरोबर शेअर करणार आहे. And if you need, you can use that website to think about this more. So I want to now shift gears and start talking about testing. What do we do when we do genetic testing? When it comes to genetic testing, we do not test the entire genome. पूर्ण पुस्तक आपण नाही वाचत. Okay? When it comes to specific genetic testing, any cancer-related genetic testing, we look at the genes and we try to find if there are any spelling mistakes in those genes. So we sequence the genes. We try to find if there are any words added or words missing from that instruction. So we do deletion duplication analysis. Historically, in 2007, 2008, we would test only 3 specific mutations, 2 on BRCA1 or vice versa, 1 on BRCA1 and 2 on BRCA2. BRCA1 and BRCA2 are the most commonly known genes associated with breast cancer. Angelina Jolie made them famous. त्याला BRCA म्हणतात in the general population. So in 2007, 2008, BRCA1 and BRCA2 चे 3 specific mutations we were testing for, sequencing कर. त्याच्यानंतर a few months, years later, we started sequencing the entire BRCA1 and 2 genes. By 2011, 2012, we were able to sequence the BRCA1 and BRCA2 genes as well as do deletion duplication analysis. Now, at that time, the lab that was doing this testing had patented these 2 genes. So other labs started testing for about 5 to 6 other genes thought at that time to be associated with an increased risk for breast cancer. The Supreme Court said genes are within people. A lab cannot patent these genes. So that was overturned. All labs could start testing for BRCA1-2 in 2013, 2014. From 2013 to 2023, in the past 10 years, we have gone from sequencing and doing deletion duplication analysis on about 6 to 8 genes for cancer to up to 84 to 92 genes associated with an increased risk for cancer on a germline level. When I say on a germline level, what I mean is 84 to 92 genes we can test for mutations that we inherited from our parents. Okay? Nowadays, we can also do genetic testing on the tumor, on the cancer, to find if there are any specific mistakes or mutations within the tumor, within the cancer. And that is called somatic testing, testing of the tumor or tumor site. So we have developed quite a lot, right? Not just that, आपण genes वरती फक्त sequencing आणि deletion duplication analysis नाही करत हल्ली. We are looking at these genes not just on the DNA level, but also on a much deeper level. We are looking at them on an RNA level also. So testing technologies have improved significantly in the past 10 years and will continue to improve and increase in the future. So how can all of this information, this is a lot of information, how can all of this be useful? Now, in someone who has had a diagnosis of cancer, it is useful to determine the extent of surgery. For example, let's take a woman who is diagnosed with breast cancer, right? Cancer is small. छोटी surgery करून जरासा tumor काढला, that is enough. That is usually the approach. But if someone has an increased risk for breast cancer based on their genes, then that small surgery may not be enough because the rest of the tissue is still at an increased risk. So your doctors may talk to you about extending the surgery, increasing the surgery or surgical site. Treatment decisions are also determined based on genetic testing. In certain people, if they have certain genetic mutations, radiation therapy is not a good idea. Because if you give that patient radiation therapy to treat that cancer, if they have that genetic mutation, they will be at an increased risk for other cancers. So it is contraindicated. So treatment decisions are based on such genetic testing. Frequency of imaging. If someone has an increased risk for cancer and they have had a surgery, instead of doing PET scans for the next 5 years while they go into remission, the doctors may decide to continue doing those PET and CT scans a little while longer, even after the patient has gone through remission, because there is an increased risk for cancer. For people with thyroid cancer, after doing a partial thyroidectomy where half your thyroid gland is removed, patients may usually be let go and not need thyroid ultrasounds for 3 years after 3 years. If there is an increased risk, the frequency of that imaging may continue or persist even after a person has gone through remission. Somatic testing, germline testing, identification of these pathogenic mutations in your genes allows our doctors to use better treatments and therapies, like targeted treatments and therapies. In fact, आता सध्या breast आणि prostate cancer मध्ये metastatic prostate आणि breast cancer, stage 4. या पेशंटसाठी if we identify specific genetic mutations, BRCA1, BRCA2, PALB2, आपण एक therapy वापरू शकतो, PARP inhibitor therapy म्हणतात त्याला, and it has known to show better outcomes. Patients do much better. The cancer sites, the metastases reduces, and lesser side effects, because that therapy are using that genetic change as a target. So you're going to the root cause of the disease in a sense. In addition to that, because of all of these therapies being available clinically now, a lot of research is also being done on the back end. So identification of these genetic mutations can allow a patient to be eligible for certain clinical trials or immunotherapies that previously may not be available. So in a patient with a diagnosis of cancer, there are a lot of things that can change based on such genetic testing. In people with family histories of cancer who don't have cancer themselves, genetic testing can also be useful because it can determine what your risk looks like. There are certain screenings that we do or we offer to our patients. Insurance covers these screenings that are based on general population risk. Everyone has a baseline risk for cancer. So everyone is being managed based on that risk. Now, a person with a genetic mistake or a mutation is known to have an increased risk for cancer. It is unfair to keep managing that patient at the general population risk. So identification of an increased risk for cancer allows your doctors to screen you much more closely, to see whether your body is developing cancer anywhere, be proactive about it. There are certain imaging studies you can do. There are certain frequency of imaging studies that can be changed. So instead of doing it every year, you may want to do it every 6 months. Or instead of doing it every 10 years, colonoscopies can be guided to be done every 2 years, 3 years, or 5 years, right? The age at which you will start these screenings also changes. Cancer is an age-dependent disease, right? The longer you live, the more likely you are, like I said before. So a lot of these screenings start later on in life. But if you are at an increased risk for cancer, your screenings need to start earlier on. And that also changes. So a lot of preventative measures can be changed. It also has reproductive implications. Some of these genes, when one copy is changed, there is an increased risk. But if your partner also carries a change in these genes, your child may be born with no working copies of some of these genes. and that can cause significant disorders in childhood. It has reproductive implications for your children. There are preventative medications available nowadays. So for increased risk for breast cancer in women, we do what is called chemo prevention, where a chemotherapy is used proactively to reduce a risk for cancer. In addition to that, when it comes to reproductive implications, I wanted to spend a little bit of time talking about ovarian cancer and family history of ovarian cancer. In women, ovarian cancer risk is low. In the general population, the risk for ovarian cancer for a woman is 2% over the period of your lifetime. Okay, so in your 30s and your 40s, the risk is much, much lower. When there is a family history of ovarian cancer, either an aunt or a grandmother, so that is called a second-degree relative. If there is a second-degree relative with ovarian cancer, your risk is slightly increased. So it goes from 2% to approximately 3 to 4%. If you have a first-degree relative with ovarian cancer, like a mother, a sister, or a daughter, the risk changes from 2% to 6%. Some genetic changes, for example, BRCA1, the risk changes from 2% to upwards of 63%, a 30 times increase in risk. And that is why it leads to certain implications to you and your life, because ovarian cancer is a silent killer. It is not something that can be screened for. We don't have good screening strategies for ovarian cancer. One of the screenings that we do for ovarian cancer today is a transvaginal ultrasound. I probe you and look at your tubes and ovaries, or a CA-125 blood draw, which is a blood test. Now, with transvaginal ultrasounds, what happens is that the cancer is not diagnosed early enough. Usually, by the time you get a diagnosis, it is stage 3 or stage 4. Okay. With CA-125 levels, sometimes they can be elevated in healthy women also. So we don't have a good screening technique for ovarian cancer. So when we find that there is a very high increased risk for ovarian cancer in the family, where it changes from 2% to 63%, your doctors may recommend doing surgery, having your tubes and ovaries removed surgically. This has reproductive implications, right? So this is information that is best received before you start making major decisions in your life. The best person, however, in the family to start with when it comes to genetic testing is the person with a diagnosis of cancer, because that will give us the most useful information. If a person has been diagnosed with cancer young, that is the best person to start genetic testing with. Because if that person comes back negative, if the result comes back negative, then we know that if there is a genetic risk, it is not detected by the testing available today. Or we know that there is no genetic risk, identifiable genetic risk. If we start testing in someone who hasn't had the diagnosis of cancer, who has a family history, and the person with the cancer has not had testing at all, now if it is a negative result, we don't know for sure that there is no genetic risk in the family. Because it's also possible that there is a genetic risk in the family, this person just did not inherit. And that becomes an uninformative negative. We can test unaffected family members, don't get me wrong. We can test people who have never had a diagnosis of cancer. But the most useful information comes when we are testing someone who has had a diagnosis of cancer. Moving on, I wanted to talk a little bit about why it is important to get this testing after talking to a genetics provider or a healthcare provider. There are a lot of tests available. Let me define first what a genetics provider is. A genetics provider could be a medical geneticist. So that means an MD doctor with a specialization in genetics. Genetic counselors, so people like me who are trained to, utilize this information, give family risk assessments, and provide this information to patients to help them make decisions about whether or not they want to pursue genetic testing. Genetics providers could also be other healthcare practitioners or professionals, so OBGYNs, oncologists, nurse practitioners, RNs with specialized training or certification in genetics. it is important that you talk to these providers before ordering or pursuing genetic testing. And that is for a variety of different reasons that I'm going to get into. First and foremost, genetic testing, for it to be covered by your insurance company. So insurance companies cover these tests. For it to be covered by your insurance company, it is always helpful that it is ordered by a healthcare professional. There's lesser cost to you. Secondly, incomplete testing is a very common case example that I encounter. So, for example, people who were tested back in 2007, 8, 10, right? They were tested for only a few genes. Now they are going around their life happily thinking that they got genetic testing done, but that is not true. They were tested for what was available back then. If they come and talk to a healthcare provider, they will know the information that there is expanded testing available, updated technologies available now, where they can get updated genetic testing and provide that useful information to their doctors and other members of their family. There have also been multiple cases where a patient has gotten testing. So I had a patient where her daughter was found to have a mutation, and she went to her wellness doctor. So this was a chiropractor. I will not take names, but this was a chiropractor / nutrition information provider, which is great for what they do, who ordered a genetic test. I didn't have access to those test results. So I kept calling the office. And my patient said, I don't have the mutation. My daughter has the mutation. My husband doesn't have the mutation. I don't have the mutation. We don't know where it came from. So that is not something that happens very typically in cancer genetics. And that made me start thinking. I called the chiropractor's office. I'm like, I want a copy of those results. Turns out he did not test her for the right genes, right? He did some sort of genetic testing, but that testing was not for what we are looking for. So we repeated the test on my patient, and she actually did carry the mutation, had an increased risk for cancer. And in fact, if she hadn't done all of the screenings that we recommended, that would have been a bad outcome for her eventually. And that is why it is important to talk to experts and specialists in that field, right? Medicine has become super specialized now. So each subspecialty has their niche, and it is important to talk to an expert within that subspecialty. Incorrect testing is also something that happens very commonly. Ancestry.com, 23andMe. These are tests, genetic tests that are available very commonly outside. 23andMe is a great company, a great lab. They have an FDA-approved BRCA1/2 test that they include on their genetic testing. But not all cancers are related to BRCA1 and BRCA2. Not all genetic risk is related to BRCA1 and BRCA2. So the pitfall here, the problem here is that a person may say that I have gotten genetic testing done, but the genetic test is not looking for what the risk actually is in the family. There are certain certifications that a lab needs to have for it to be qualifying as a clinical genetic test. Okay. CLIA and CAP certified labs are labs that provide clinical genetic testing. Manje, the information that they provide is validated, is true, and can be used to make medical decisions. There is a lot of genetics fraud happening, insurance fraud happening across the United States, where I have had patients come and tell me, I gave my sample for genetic testing outside a Sam's Club. I've gotten this test, but I never got the result. Those are not clinical tests. Those are samples and testing being done to defraud insurance companies, to get money from your insurance companies without actually giving you any useful information. So it is very, very, very important not to do these tests willy-nilly, because another thing that I want to make you all aware is your genes are your genes. You're born with them. You're going to live with them for the rest of your life. Giving these samples willy-nilly, wherever, you're giving your data, in a sense, to people we don't know how they're using that data and that information. right? Lastly, I wanted to talk about second lastly, wanted to talk about incorrect interpretation of results. So we spoke in the beginning of this session of how all of us have mutations, right? And it's pathogenic mutations that cause an increased risk or that cause disease. Now, when it comes to genetic testing, sometimes we'll find changes or alterations in our genes that we have no idea how they impact the functioning of the gene. We call them VUSs, variants of uncertain significance. A VUS is nothing but a change. We don't know if that change stops the gene from working properly or is just a normal human variation. For example, let's say there is a word and there is a single letter change in the word. A letter is added. Now that could mean COLOR color or COLOUR color. There is a letter added, but doesn't change the meaning of the word, right? Color, same. But as opposed to that, it could also be red, where RED red and READ red changes the meaning of the word. It is a single letter added, but it changes the meaning entirely. So when we find a variant of uncertain significance, we just know that there is a single letter added. We don't know if it is a color difference or a red difference. And that becomes hard to interpret for people who are not familiar with genetics. So people may interpret that as, oh, there is a mutation and recommend surgeries, where in fact that mutation or that change could later be determined to be a color change that doesn't add to your risk. So now the patient has undergone a surgery, which is life-changing, for a risk that does not exist. And it is because of this risk of incorrect interpretation of results that, again, I recommend talking to an expert in the field before ordering such testing. And lastly, testing without informed consent has its own implications. There was a law passed in 2008, right, that says that genetic information, so it's called the Genetic Information Non-Discrimination Act, or GINA. It states that as a civilian, your genetic information cannot be used by your healthcare company or your employers to discriminate against you. If you do the genetic testing, these results become a part of your medical records, but your insurance company, your health insurance company cannot use this information to say, we are increasing your premium. This is a pre-existing condition. So this is important information to know before you order a genetic test or you try to get a genetic test. The other aspect of this is the protective law does not extend to life insurance, disability insurance, or long-term care insurance, right? Any of these plans that exist prior to pursuing genetic testing are not retroactively affected. But if a person doesn't know, gets this test ordered, and then tries to buy life insurance, these results will impact how their policy is determined, how their premiums are determined. And that is important information to know, I feel like, in the long run. The other thing is, not everyone may want to know about this risk, right? So if a doctor orders this test without talking to their patients, this is information that you live with for the rest of your life. You may not want to know this information. Sometimes you may not want to know this information now. 5 years down the line, you may want to know this information. So it is this conversation between the provider, getting that informed consent as to what are we trying to find out is very important. Because genetic information doesn't just affect you as an individual in the moment, it affects you for the rest of your life, and it affects other members of your family also. There is always a way to find out more information in the future. But once this information is available, there is no erase button in our brain. And that is why it is really, really important to consider whether or not we want to find out this information. So currently, in the United States, you can go onto this website to find a genetic counselor. Genetic counselors are people like me who talk to patients about their family risk, help patients understand what that risk looks like, and discuss genetic testing options with them. You can also talk to a geneticist, your OBGYN, or your primary care physician about such testing. Current status in India is that genetic testing has been provided by other medical professionals such as gynecologists, pediatricians, and oncologists. Great doctors, but not trained in human genetics or genetic counseling. In some institutions, there are certain genetic counselors that are available. So that is where the current status is in India. We spoke a lot about cancer genetics. I just wanted to mention that there are other things that you can talk to a genetics provider for. So it doesn't mean that every time someone talks to genetics, it's about cancer. People can talk to genetic counselors or get genetic testing before giving birth to their children to find out, is there a risk, a reproductive risk for any offspring? Women get genetic testing during their pregnancies. It is called prenatal testing. A child may be born with a birth defect. Pediatric diagnoses are made using genetic testing. A child may have developmental or intellectual disabilities or autism. At that time, you do pediatric genetic testing. Cardiac genetic testing has become very common. Heart abnormalities, structural or arrhythmias are known to be genetic. So cardiac genetic testing has started becoming very common. There are certain parts of the country, I think the West Coast majorly, and British Columbia and Canada, there's a lot of psychiatric genetic testing that is being done. We are noticing that like cancer being multifactorial, there is a genetic impact in psychiatric conditions as well, such as schizophrenia, bipolar type 1, bipolar type 2. So a lot of psychiatric genetic testing is being done. Neurological disorders like Alzheimer's, dementia have certain genetic components. We are not doing genetic testing as commonplace, but that is available. Huntington's disease is a neurological disorder, and people get genetic testing for that. So there's a variety and a slew of things that a person may be seeing genetics for, and not every genetic test will tell us about our risk for cancer. I would like to stop here and see if there's any questions for me.
Thank you. Very informative session. सुरेश काका, मी एक आभार प्रदर्शन करतो आणि मग आपण क्वेश्चन्स घेऊया. थँक्यू. म्हणजे फारच इन्फॉर्मेटिव्ह सेशन होता हा. काही जसं म्हणजे हा विषय असा आहे ज्याच्यामध्ये गैरसमज खूप होतात आणि सगळीकडेच करायचं असतं का किंवा सगळीकडे करायचं नसतं का, आणि मग देन इज देअर एनिथिंग दॅट वी कॅन डू, आणि प्रिकॉशन्स किंवा जसं आपण गाडीच्या याच्यामध्ये म्हणतो प्रिव्हेंटिव्ह मेंटेनन्स आणि ब्रेकडाऊन मेंटेनन्स, असा प्रकार आहे का इथं? म्हणजे बेसिकली इट वॉज रिअली अ ग्रेट इन्फॉर्मेटिव्ह सेशन. आणि लोकांना आता भरपूर शंका असतील, आय नो, बिकॉज दिस इज द टॉपिक वेअर पीपल हॅव थॉट्स ॲज वेल एज डाऊट्स. आणि थोडीशी इन्फॉर्मेशन अर्धवट किंवा म्हणजे ते हाफ नॉलेज वगैरे प्रकार असतो तसा प्रकार आहे इकडे. पण येस, थँक्यू रचिता, आज संडे सकाळी सेशन घेतल्याबद्दल. आणि थँक्यू टू दीपा, आय थिंक शी इज द कॉन्टॅक्ट फॉर यू, आणि आम्हाला तुझी ओळख करून दिल्याबद्दल. थँक्यू उल्का अँड दीप्ती to arrange this session. They are at the admins of Arogya Dham, Maharashtra Mandal Chicago. मी Arogya Dham चालू केला लास्ट इयर आणि यावर्षी पण आपण चालू ठेवतोय तो विथ डिफरंट इन्फॉर्मेटिव्ह सेशन्स. आणि IT टीम आपली, ते म्हणजे मी आहे तो. तर युजली आपले फ्लायर्स बनवणे दीपाची टीम असते, आणि झूम सेशन घेणे, युट्यूब लाईव्ह करणे, ऑल दिस लॉजिस्टिक्स अँड IT वर्क युजली आपली IT टीम करते. थँक्यू टू ऑडियन्स. आय नो विषय जरी निश किंवा स्पेसिफिक असला तरी तुम्ही आज अटेंड केलात हा विषय. धन्यवाद. मी आता उल्का, आता आपण क्वेश्चन्स घ्यायचे.
हो चालेल. या
सुरेश काका.
Oh, Dr. Nikam, तुम्ही PhD आहात का नाही ठाऊक नाही, but you deserve the title doctor, because हा इतका महत्वाचा विषय आहे की prevention is the basis of medicine to me. कारण personally, when I was in primary care, if there was something I could prevent or something I could diagnose early, that was the greatest joy to me personally. So I really appreciate your talk. आणि प्रश्न असा होता की काय म्हणजे एवढी इन्फॉर्मेशन झाली आहे सगळीकडे आणि एवढं महत्वाचं टॉपिक, तर आता प्रिव्हेंटिव्ह केअर या देशात कमी प्रमाणात उपयोगात आणली जाते असं मला वाटतं. म्हणजे भारतात जवळजवळ नाहीच, कारण कोणी डॉक्टरकडे म्हटलं तर जात नाही असं. तर आता बदलत आहे, पण हे जे सायन्स
सगळेच डॉक्टर असतात,
खूप वाढावं हीच इच्छा. आणि प्रश्न एकच आहे की टायरोसिन कायनेज हे जरा टेक्निकल वर्ड आहे, तर त्याचा काही संबंध आहे काय सगळ्या कॅन्सर प्रमोशन किंवा याच्यात हे जे एन्झाइम आहे?
No, absolutely. TKIs किंवा tyrosine kinase inhibitors, we encounter them very often आता somatic genetics. So when we are testing the tumors, we are looking at TKI pathways. Lung cancer मध्ये खूपसं TKI target केलं जातं. Honestly, the side of things that I work in is inheritance. So I don't encounter those pathways or talk to my patients about that. My previous master's is in biotechnology. मी थोडं कॅन्सर रिसर्च केलेलं असल्यामुळे मला ह्याच्यात नॉलेज आहे. We do a lot of molecular review when treating patients with cancer these days. So we have molecular tumor boards where oncologists, lab genetics, so researchers from the scientists from the lab, and then clinicians like me who are genetic counselors or geneticists sit together and discuss the molecular basis of the cancer and determine which is the best treatment pathway or why is it so and what needs to be done for family members. So TKI has been implicated, depends on the disease site and depends on the disease progression is how I would answer that question.
Thank you. Thank you. Very nice talk. Thank you.
कोणाला काही क्वेश्चन्स?
प्रश्न नाही, पण एक थोडा फीडबॅक द्यायचा आहे. रचिता सेशन वॉज रिअली ऑसम. आय थिंक युअर नॉलेज, द वे यू प्रेझेंटेड, इट वॉज फ्लॉलेस. म्हणजे खूपच छान प्रकारे तुम्ही सेशन घेतलं. मी एक कपल ऑफ इयर्स बॅक, म्हणजे माझा मुलगा जेव्हा 11वीत होता तेव्हा तो बायोलॉजी सब्जेक्ट होता आणि त्याच्यामध्ये तो सेलचं त्याचा तो वाचत होता आणि ते मी बुक वाचता ते सेल वाचलं आणि खूप इंटरेस्टिंग वाटलं. आणि मी कपल ऑफ वीक्स आय वॉज जस्ट रिडिंग दॅट अगेन अँड अगेन. खूप चांगलं वाटलं आणि थोडंसं आध्यात्मिक थोडं आता त्या डायरेक्शनला चालल्यामुळं मला म्हणजे एक स्थूल पासून सूक्ष्मापर्यंत जो प्रवास असतो त्याच्यामध्ये स्थूल शरीरामध्ये किती सूक्ष्मात जाऊ शकतं किंवा सूक्ष्मापर्यंत जायसाठी शरीराची किती माहिती मिळू शकतं. तर हे सेल जो कन्सेप्ट आहे तर तो म्हणजे खूप जाणून घ्यायला आवडेल. नॉट ओनली फ्रॉम द कॅन्सर पर्स्पेक्टिव्ह बट इन जनरल, राईट. म्हणजे खूप काही गोष्टी समजून घेण्यासारख्या आहेत. मला वाटतं थोडंसं अजून इंटरॅक्शन करायला आवडेल. मी आता हे टॉपिक डायव्हर्ट करायचं नाही करणार. म्हणजे दिस इज स्पेसिफिक टू कॅन्सर अँड स्पेसिफिक टॉपिक, बट व्हेरी कीन टू इंटरॅक्ट विथ यू फर्दर अँड एक्सप्लोर दिस एरिया.
Can you put the name on the talk, the book or something you mentioned? कुठलं काय बुक म्हणाला का तुम्ही?
विवेक बुकचं नाव काय?
नाही, मी मुलगा 11वीत असताना त्याचं बायोलॉजी.
11वीचं बायोलॉजी.
11वीचं बायोलॉजी.
ओके.
त्याच्यामध्ये मी ते सेल आणि त्याच्यामध्ये मायटोकॉन्ड्रिया, मग तुमचे पॉवर सेल असतो, प्रत्येक सेलमध्ये पॉवर कशी असते आणि ते अप्रतिम. मग खूपच ते
ज्यावेळी आपण 11वी-12वी होतो त्यावेळी आपण स्वतःचे पुस्तक वाचलो नाही, आता मुलांचे पुस्तकं वाचतो एवढंच.
खरंय. आणि ते इतकं इंटरेस्टिंग वाटतंय आणि त्याला म्हणजे समजा एका महिन्यामध्ये सगळंच संपवायचं होतं, म्हणजे खूपसं काही असं सिलेबस. पण मला 1 महिना नुसतं सेल समजत नव्हतं. म्हणजे मी म्हटलं यार हे एज्युकेशन सिस्टीम अशी आहे म्हणजे पण
मला त्याच्यावर नाही कळलं. रचिता, तू म्हणालीस की यू हॅड मास्टर्स अँड ऑल. म्हणजे आमचा एक MMC युथ म्हणून एक ग्रुप आहे. हा यांनी विवेकने विषय काढला म्हणून मी बोलतो की त्या युथसाठी काय म्हणते त्याला, इन्फॉर्मेटिव्ह किंवा जनरल नॉलेजचं सेशन घेऊ शकशील का ऑन दिस टॉपिक. म्हणजे दिस इज व्हेरी इंटरेस्टिंग टॉपिक just for
Okay.
the cells and the molecule within the body and how they work and how they get the energy or how they
आवडेल
provide
मला.
energy to all functions.
जनरल बेसिक सेल्युलर बायोलॉजीचं जनरल मी टॉपिक घेऊ शकते. आणि ऍक्च्युली जर युथ आपण टॉक्स करत असतो तर कोणाला इन्फॉर्मेशन करिअर ह्याच्यासाठी कसं ह्या फील्डमध्ये, दिस इज नॉट अन MD डिग्री. तुम्ही
Right.
डॉक्टर न बनता मेडिसिन मध्ये कसं तुम्ही ऑल्टरनेट करिअर्स करू शकता, दॅट इज ऑल्सो अनदर थिंग दॅट आय कॅन टॉक अबाउट. कारण अलाइड
ना.
हेल्थ प्रोफेशन्स खूप आहेत आपल्यात.
चालेल ना. ऍक्च्युली आय विल टच बेस विथ यू आफ्टर दिस कॉल आणि आपण एक सेशन घेऊया नक्की. म्हणजे आपल्याकडे आपला युथ म्हणजे 5 ते 25 वयोगटातला आहे. तर इन्फॉर्मेटिव्ह पासून जनरल नॉलेज पासून ते करिअर काउन्सिलिंग पर्यंत म्हणजे सगळंच त्याच्यामध्ये कव्हर होतं. तर आपण एक असा सेशन घेऊ जिथे इन्फॉर्मेशन पण आहे आणि मोठी मुलं जॉईन झाली तर त्यांना आपण एक काहीतरी गायडन्स देऊ शकू. आणि दीपा, तुला एक आहेस का दीपा?
आहे.
हा, तुझं ग्रॅज्युएशन सेलिब्रेशन, तुला स्पीकर मिळाली आहे.
हो हो.
फॉर करिअर
आहे आहे.
इन द मेडिकल फील्ड. ठीक आहे, लक्षात तिच्याशी बोलून घे. ठीक आहे. शशीताई, तुम्हाला क्वेश्चन आहे?
मला एक प्रश्न विचारायचा होता की डू यू हॅव एनी आयडिया what is the risk factor for environmental effect on the mutation? I mean, mutation of genes.
So environmental effect definitely asto. Environmental effect can be UV radiation, how much we are exposed to the sun, ionizing.
Now, what is the risk factor? What is the risk factor associated with the environmental?
So the exact specific
mutation
risks we cannot quantify because each
I see.
person
Okay.
and each body, the way it interacts with the environment on a molecular level is very different. So मी तेच म्हणत होते ना की each person has a different threshold of what risk factors in the environment their body can and cannot tolerate. Nowadays, some labs are doing a polygenic risk score where they look at the overall genetic makeup and try to find out if there are any specific things in the genome, the overall book, that are causing a person to be at an increased risk to environmental risk factors. But that science is not very robust right now, and it is very reliable right now.
Well, I know some cases where the people have got the cancer and they changed the environment and the reverse mutation took place. So they were cured of the cancer. And that is very good news. I mean, we cannot they don't have to give up the hope. They can try changing the environment and see if the reverse mutation can take place so that their cancer is cured. I read some information and I have now some personal friends who saw the changes because of the environmental change. That is very encouraging. That's what I wanted to say.
And I think, Shashitai, actually towards that, like I think Vivek Dadani pan mantla ki all of this is still in its infancy. We are still learning a lot more. We haven't understood everything there is to be understood about the human body. We are still learning about our genome and our genes. So all of these things, it is very dependent on that particular case, that particular situation. And I agree with you 100% ki one of the most important things when dealing with a cancer diagnosis or anything like that in your family is not losing hope. Our mental stress and all of these other factors also add to our risk on a cellular level and biologically on our body. We know that. So not losing hope, keeping a positive mindset and attitude and trying to change our environment, being healthy is always a good thing.
I just wanted to add the last sentence that you are really incredible. You have very good knowledge at the tip of your hand or tongue, and you can really you can really be a great counselor. I mean, that's what I can say. It's very good. I really enjoyed your talk.
Yeah, no, I can't agree
Thank
more.
you.
You are very presentable, very nice.
Thank you. I think Sameer Kulkarni put in the chat, the mic is not working.
अच्छा, एक minute. अच्छा, my mic is not working. A question though, are there evidences linking mental and emotional state of being to reduce or increase the risks?
There is a clear evidence where we have noticed that high anxiety, high stress situations, consistent inflammation through the body. So all of these factors add, like I said, chronic medical conditions like gastritis, pancreatitis, colitis add to our risk for cancer. Now, when you think about it, that is inflammation of our parts of the body. When you think about anxiety, stress, depression, it is a kind of inflammation of our emotional well-being. So definitely when you think about all of these things as a multi-systemic form, it does add to our risk, and it is better to reduce these stressors as much as possible. There is no medical quantifiable data available right now where we say that this percentage of people with anxiety have an increased risk for these types of cancers. But we do know that when a person is going through high stress situations, there is a higher incidence of cancer diagnoses.
Thank you. Thanks.
Next take आहे, will you be able to share the slides? Rachita, if these are not kind of proprietary slides, तर share करू शकतील का?
Oh, definitely, me share karte. If you don't mind, I'll add a watermark of my name at the bottom, just because that is something that I need to do for my medical licensure liability.
Correct. No, that's perfectly fine. Yeah,
Otherwise, I can share these slides. I'll share them with Deepti and Deepa Maushi.
हो. I know. दीपानी सांगितलं
प्रसाद.
तुझी भाची आहे, तर मी म्हणलं आता हक्कानीच बोलू आपण. हा, रेखाताई बोला.
मी बोलते. एक रचिता फारच सुंदर प्रेझेंटेशन झालं, पण आता हे स्ट्रेस आणि इमोशन्स ह्याच्यावरनं जे आपण बोललो, तू सांगितलंस की कसा त्याचा इफेक्ट होतो, याचं उत्तम उदाहरण माझ्या घरात आहे. माझ्या सासूबाई आता 100 वर्षाच्या आहेत. आमच्या घरी त्या मागचे 35 वर्ष राहतायत. त्यांच्या दोघी बहिणी ब्रेस्ट कॅन्सरने गेलेल्या आहेत. म्हणजे जेनेटिकली काहीतरी आहे तिथे, पण 35 वर्षात त्यांना कुठचाही स्ट्रेस नाहीये. त्याचा परिणाम नक्कीच त्यांच्यावरती झालेला आहे, म्हणून त्या 100 वर्षापर्यंत जगले आहेत आणि ब्रेस्ट कॅन्सर झाला नाहीये. म्हणजे स्ट्रेसचा डेफिनेटली इफेक्ट आहे. त्यांना भरपूर डायबिटीस आहे, पण त्या भरपूर गोड खातात, काही होत नाही त्यांना. शुगर नॉर्मल.
म्हणजे
डायजेस्टिव्ह ट्रॅक्ट त्यांचे म्हणजे
तुम्ही त्यांची काळजी चांगली घेताय.
आता घरातच आहेत आणि काळजी तर घ्यायला पाहिजे ना, पण म्हणजे माणसाचा स्वभाव पण असतो. काळजी घेऊन सुद्धा काळजी करणारे लोक असतात, नाही असं काही नाही.
सराउंडिंग मुळे कधी कधी स्वतःला स्ट्रेस येतो, अरे बघितलं त्याचं बघितलं, मग माझं कसं होईल वगैरे. दॅट इज देअर. येस,
काही नाहीये
आणि ते आपण स्टॉप करू शकत नाही. तुम्ही किती का काळजी घ्या.
नाही, त्यांच्या मुलीला पण झाला होता, तिला खूप स्ट्रेस आहे. स्वतःच डॉक्टर आहे, तिला पण झाला होता, बरी आहे ती, पण मग तिला पण झाला होता, मग त्यांना झाला नाही, कारण नो स्ट्रेस. म्हणजे आपण ते शिकायला हवंय, स्ट्रेस घ्यायचा नाही सगळ्या गोष्टींचा.
दिल पे मत लो, हात पे लो.
पण आपण दिल पे घेतो ना.
चालेल,
पण छान झालं, खूपच छान झालं.
खूप छान सेशन.
Thanks. I think Shweta also said if it's all right to touch base with you on pediatric developmental delay screening. तिने असं केलेलं आहे. श्वेता,
चालेल, नक्की. आय विल शेअर माय ईमेल आयडी. मी पर्सनल ईमेल आयडी शेअर करेन, आणि त्याच्यावरती तुम्हाला जर प्रश्न पाठवायचे असेल पाठवा. मला जसा वेळ मिळेल तसं मी उत्तर देईन. आय कांट गॅरंटी की मला इमिजिएटली देता येईल उत्तर. मी सध्या तरी वॉशिंग्टन युनिव्हर्सिटी मधली ओनली कॅन्सर जेनेटिक काउन्सिलर आहे, त्यामुळे मी खूप पेशंट्स बघते आणि दमते त्याच्यामुळे मला जरा वेळ लागतो उत्तर द्यायला. पण मी नक्की तुमचे प्रश्न वाचून उत्तर द्यायचा प्रयत्न करेन. आणि जर तुम्हाला जास्त एक्सपर्टीजची गरज आहे, माझ्या स्कोपच्या बाहेर आहे, तर मी नक्की तुम्हाला कनेक्ट करेन विथ द राईट एक्सपर्ट्स.
आणि म्हणजे आता तू बोललीस, पण जस्ट बेसिक क्वेश्चन नाव फॉर युअर सेल्फ. आता तू म्हणतेस की दिवसभर तू डिफरंट पेशंट बघते, मग डिफरंट ते पेशंट्सची जरी त्यांची काय म्हणते त्याला स्कोप इज सेम, लाईक जेनेटिक कॅन्सर काउन्सिलिंग करतेस वगैरे, पण every person has a different ability or behavior to respond to your counseling. आणि घरी आल्या मग हाऊ डू यू टेक दॅट आउट ऑफ युअर माइंड स्ट्रेस?
अजूनही प्रयत्न चालू आहेत. आय डोंट थिंक पण एक चहाचा कप, थोडी बटाटे वडे, भजी तळायची, एक कुठला तरी पिक्चर शाहरुखचा लावला होऊन जातं ना आपलं.
क्या बात आहे, सही आहे, सही आहे. गुड गुड.
ही हौशी आहे तशी. हो.
नाईस, चालेल. एनी अदर क्वेश्चन और कमेंट्स? ओके, थँक्यू रचिता वन्स अगेन. आपण पुन्हा भेटू. जसं युथचं मगाशी बोललो मी, आणि दीपा विल कनेक्ट विथ यू फॉर द ग्रॅज्युएशन सेलिब्रेशन नाव. तर सी यू देन.